afternoon, and thanks for joining us. I'm Judy Simpson. Today our focus is on men's health and the causes, diagnosis, and treatment of prostate cancer. 1 in 7 men will be told they have prostate cancer. While no cancer diagnosis is easy, increased awareness and screening means more men are being diagnosed early before the cancer has spread. As with many diseases, risk factors such as age, race, and family history can't be controlled, but there are ways to lower your risk for prostate cancer. In partnership with the University of Vermont Cancer Center, we're able to draw on a wide range of cancer experts who can provide reliable and up-to-date information for you and your family. This afternoon, I'm talking with Dr. Jim Wallace, UVM Associate Professor and Medical Director of Radiation Oncology at the UVM Cancer Center, and Dr. Allison Landry, UVM Assistant Professor of Primary Care Internal Medicine. Welcome to both of you.
Thank you.
Before we begin our discussion, I'd like to ask both of you a little bit about how you came to be working together.
I'll start off with that.
Sure.
So, at the Academic Medical Center in Burlington, we're looking for unique ways of getting together and developing relationships with research partners. And one of the unique things that we have here is close proximity to working with specialists and primary care people in the same building, in the same office, and sharing patients very closely. And frankly, we share an employer. So it's a nice, easy way to form relationships. And prostate cancer screening was something that became important to me, something personally interested in, but I don't do prostate cancer screening as a person who treats prostate cancer, so I needed to develop relationships with folks that do that.
Mm-hmm. And so for you, what's the partnership mean for you as far as the work you do?
Well, it's really exciting to be able to work together and come to a common ground about how to approach prostate cancer screening, because sometimes there are different perspectives that a urologist might bring to the table versus a radiation oncologist like Jim versus the primary care when we're the ones having the conversation about screening with the patients to begin with. So it's nice to be able to work together and come to the same page about how we want to approach it as a group.
Mm-hmm. Jim, let's remind our viewers what prostate cancer is.
So prostate cancer is an abnormal growth of prostate cells within the prostate gland. The prostate gland is a structure that sits beneath the bladder. And as men get older, our prostate glands get bigger, and many men have symptoms related to an enlarged prostate gland. Usually those symptoms are related to just our prostate glands getting bigger and not cancer. But in some men, they do develop this abnormal growth of these cells, which can cause local problems, difficulty with urination being a classic one, but it can also over time spread to other parts of the body and become life-threatening.
I see we have a slide here that sort of shows where the
diagram of the structure of where the prostate gland is, and
what the different stages look like. So who's the greatest risk to be diagnosed with prostate cancer?
Well, so risk factors for prostate cancer include African American race. Those men have higher risk. As well, people who have a family history, so a father or a brother who had prostate cancer, those men are at higher risk of having prostate cancer.
What are some of the warning signs that can lead to a diagnosis?
Most prostate cancer doesn't have any warning signs.
Really?
Most prostate cancer doesn't have symptoms unless it's more advanced. As Jim said, when it spreads beyond the prostate into the lymph nodes or to the bone, then there can be symptoms. But in the earlier stages, no. So that means that most men are being diagnosed through screening. And that screening is the PSA test.
How does that work?
So the PSA test is a blood test. It stands for prostate-specific antigen. And when it's elevated, that means it may correlate with risk of prostate cancer. But unfortunately, that test is not as accurate as we'd like it to be. In fact, you might want to put the next slide up. And so that means that what men have to do is go through a biopsy to really determine do they have prostate cancer or not. And the PSA test can have many false positives, meaning that it's elevated, but men don't have prostate cancer on the biopsy, and also some false negatives. So sometimes we miss prostate cancer because the PSA looks fine, but they in fact do have prostate cancer.
What are some of the popular myths the patients hear about prostate cancer?
So when I meet men who have been diagnosed with prostate cancer, they almost always know somebody that has had it. And I think probably the most common myth is that whatever their neighbor or their brother or their uncle had for treatment is what they're going to get for treatment. And we really have to talk with men in great detail about the fact that there are some prostate cancers that are very small, slow growing, and we do not need to treat them. And that's sometimes hard for men to understand, that they have such a small, slow growing cancer that doesn't need treatment. But on the opposite end of the spectrum, there are men with big, bad, potentially fast-growing cancers, and we have to treat them very, very aggressively. So I think the myth is more relating to men individually about their specific cancer and try to dissuade them from getting too much advice from people who've had cancer and maybe have done quite well with their therapy, but it might not apply to them at all.
Is that one of the big issues with this particular cancer, is that it's really very different for everybody?
It's very different for everybody, and we pay a lot of attention to three specific things. The PSA, which is helpful in giving us a prognosis, but also how big the tumor is, we call that the tumor stage. And then the grade of the cancer, how aggressive it looks like under the microscope. In men with low PSAs, a small tumor, and a low grade, again, they frequently don't need any treatment at all, where men who have big tumors on staging, a high PSA or a higher grade, we have to be very, very aggressive with their cancer, and sometimes we still can't cure them.
Is there a particular age where men should start thinking about, maybe I should ask for a PSA test, or what do doctors recommend? What do you recommend for your patients?
So we're recommending that men start having that conversation around age 45 with their primary care physician, especially if they are at higher risk, if they have some of those risk factors. It's important to have a discussion a little bit earlier for especially those men. And the age group that we're recommending to have this conversation is really up to age 69. So younger than 45 and older than 69, the evidence really doesn't show that there's any benefit to screening. But in that age group, middle age, that's when we can have the highest yield for screening and detection of aggressive prostate cancer.
So does prostate cancer affect reproductive health?
So the prostate cancer itself rarely does, but these are, again, they tend to be in men that are older and frequently beyond their kind of typical reproductive years, but it's not always true, and men are very interested in how they can maintain normal reproductive health if they can. Treatment of prostate cancer, namely taking the prostate gland out or delivering radiation therapy, can affect the function of the prostate gland, which is to make fluid that our sperm goes in, and can frequently make it difficult for men to get erections. So it's really probably the treatment that's more important than the cancer with respect to how we talk to men about their reproductive health and their lifestyle and quality of life overall. One of the issues we run into is we don't want to overtreat people because of issues and side effects like those.
Right. And so, Allison, again, what's the history of screening for prostate cancer, and what are some of the current methods for screening and follow-up treatments?
Yeah, so this is very interesting to me. It used to be that primary care doctors would screen men very routinely with a PSA test, maybe even every year, just part of their routine screening labs. And the evidence shows now that that does more harm than good, that approach. So more men are potentially being harmed through overdiagnosis, overtreatment of prostate cancers that may never have been a problem for them, through just routine blanket screening. So the recommendations now advise men to have a conversation with their primary care provider and really individualize the decision to screen, because this decision to screen is not right for everybody, and it depends on many factors, and importantly, it depends on what's important to the men in this process, because there are harms as well as benefits to be considered.
Which is one of the reasons why, again, this cancer has been so hard to understand for a lot of people.
Yeah.
And so you're currently enrolling volunteers in a new reproductive, or proactive rather, research study at UVM called MAPS. What's that about?
So MAPS is a study, MAPS stands for Modern Approach to Prostate Cancer Screening, and it's really based on two things, but I'll tell you how it started. It started with the majority of men who I see with prostate cancer are diagnosed early based on screening, but because of the controversy and lack of clarity about prostate cancer screening, occasionally we will see men who have widespread disease at presentation. They're not curable. And when you see a man who maybe could have benefited from getting screened at a younger age and didn't get screened, it's frustrating and bothersome. So we felt maybe there would be a better way to screen men using PSA, but in a very specific way. So that was the original impetus of this program, was working with our primary care colleagues and coming up with what population should be screened, how frequently should they get a PSA, and what do we do with the result. So that was the beginning part of it. But in addition, the thing that we're really asking for some help from our community now is we think there might be a test better than PSA that has not yet been identified. So we're looking for men that we can draw blood on them and store it in a freezer for years, and some of them we know unfortunately will develop prostate cancer. So we can go back and look at their blood before they had a diagnosis of prostate cancer and see if there are any markers in there that might have identified or been a more specific identifier for them developing prostate cancer, or specifically developing a prostate cancer that we know is worrisome or potentially life-threatening.
So anybody who's interested in, any man who's interested in volunteering for this, it is a routine blood test? Is that basically just a blood draw?
So for people that are interested in being part of that component of the study, we have to do the blood draw in a very specific way. It's just a blood draw from the patient's perspective, but we have to do it in a facility where we can get the blood frozen very, very quickly, because it has to be stored in a very specific way to look for some of these very fragile biomarkers that we don't even know exactly what we're going to be looking for. So we have a very quick, from the time it comes out of somebody's vein into the freezer, we want it to be very, very quick. So we have to talk to the man, have him come to our place, consent to be part of the study, and then have his blood drawn. And
why did you select men between the ages of 45 and 69?
Well, they're the ones that we're now currently screening, so it seemed like the natural group of men to have the conversation with. So men can get involved in this study either through their primary care provider, and right now it's only for providers that are that work at the University of Vermont Medical Center primary care practices, or they can reach out directly to us if they're interested in taking part in the study. But again, they do have to have UVM Medical Center primary care providers.
And about how many people do you think you'll be using for this study? Or how many would you like to have?
We'd like to have a couple hundred for this part of the study. In reality, to do this well, and we're working with colleagues around the country to bring this more broadly, we're going to ultimately hope to have thousands of men's blood stored. Some of them, again, we know because of the numbers we talked about earlier, will develop prostate cancer. So those will be the blood that we'll be very, very interested in looking at in the future.
And what information do you hope this study reveals, the best case scenario?
Best case scenario would be two things. One is that we identify a way of screening for prostate cancer that doesn't expose men to the risks of biopsies and treatment if they don't need it. And the other, the ideal would be that we could find a test, a blood test of some sort, that will identify, that'll be better than PSA, that will identify prostate cancers that are meaningful and that need to get treated, but frankly ignores some of these other little cancers that probably don't really need any intervention at all.
But if you're a patient and someone says you have cancer, I mean, that's all you hear. You don't hear the, well, it's not that bad, or you don't need to be treated. And I would think for a patient, that'd be, what do you mean you're not going to treat me? But that goes to the individual case in this.
It does, and it takes us, and then it takes us working with our primary care colleagues who have the relationship with the patient to have those conversations and reassure them.
Yeah, it's a lot of communication.
Well, that's just it, too, because people aren't used to really being advocates for themselves when they go to the doctor's office. I'm sure you probably see this with some of your patients. Anything wrong? Nope. Everything's great.
Yeah.
And so what do you think is the first step for folks to really take that leap and say, you know, I think there might be something going on?
Well, I think it's on primary care providers to also put this on their list of things to be asking men about. That is something that we really do need to initiate that conversation in most cases. Because again, in early stages, men are not feeling bad. They don't have symptoms. And so we need to be talking to them about whether screening is right for them. And yes, in terms of overcoming barriers to coming to the doctor, that's a big one.
Right.
And making it, you know, it's just a conversation. It's just potentially a blood test for this part of things.
And really important because you were saying 1 in 7 men will be affected by this.
That's right.
And so switching topics now a little bit, women's health. You've got a long-running conference coming up next month that you want to remind our viewers about.
We have a very successful conference. It's been running for now a long time. Hundreds of people come, and it's really become a part of everybody's calendar in the cancer world, something that we kind of base our fall around. We know when it's going to be. I'll be speaking this year at a women's health conference, but frankly, I'm going to be trying to sneak in a little bit about the prostate cancer screening study. But it is really one of the landmark things that we do at the Cancer Center is try to provide education for providers in our community about cancer, and specifically in this case, women's cancers.
And also, too, we should mention that you should check out that website because there's all kinds of things going on that day for just about everybody.
Everybody. Yep. Providers, physicians, patients, families.
And once again, we've got about a minute left. What would you like to tell our audience about talking to their doctors and starting that conversation?
It's just a conversation, and it's also all about you. It's about what's important to you as the patient. And so you are an equal player in this decision about whether prostate cancer screening is right for you. Your provider can talk to you about risks and about what the process might look like for you and whether it's appropriate for you. But ultimately, it's your choice.
All right. Well, I want to thank you both for joining me today.
All right.
That's our program for today. Thanks for joining us. I'm Judy Simpson. I'll see you again next time on Across the Fence.